So good morning, good afternoon, good evening. Welcome everyone to this 717 Alliance Global Learning webinar. For those of us that have been attending these webinars, last year in October, we had a global learning webinar that was focused on bottlenecks insights, essentially identifying those things that slow us down in outbreak detection, notification, and response. Getting a very good understanding of the root causes of bottlenecks, and then identifying the appropriate actions that would be needed to close those gaps. Today, we're going to take that a bit further. We're going to look at a specific bottleneck that is particularly challenging, and this bottleneck is low clinical suspicion. Now, for this bottleneck, I think that it's important that we really focus on it because it has implications for early detection and response. It has implications for healthcare worker protection. It also has implications for our ability to continue to deliver health services even in difficult and challenging contexts. Now, today, before we start the webinar, we wanted to have a better idea of who is attending and participating with us. And so we're going to be starting off with a poll to get to know you better this time. This is going to be a quick poll. The first question, what is your primary role? Please select an option in English or French or Spanish. The next question, what contributes to low clinical suspicion in the places where you work? And our third question, if we were to strengthen clinical suspicion starting tomorrow, where would you begin? And so from the results, we see about 6% frontline clinicians, 1% facility management, 13% district or subnational health management teams, 10% national public health, 34% surveillance, 20% NGO partner, 9% academia, and other 8%. So we have a really diverse audience today, and we're really thrilled that you were able to make it. So today we're pleased to have a really outstanding presenter join us. Dr. Stacey Mearns is going to be presenting today. She's the Director of Primary Health Care at Resolve to Save Lives. And she's a public health professional who has worked for more than 17 years with wide-ranging experience in the health sector as well as in humanitarian and outbreak emergencies. She's worked in more than 20 countries, delivering both clinical care and public health programs. And in 2021, she received the Order of the British Empire Award by Her Majesty Queen Elizabeth II in recognition to a lot of her humanitarian contributions. Stacey received her medical degree from the University of Birmingham. She's a member of the Royal College of Physicians of the UK. But she also holds a Bachelor of Science in International Health from University College London and a Diploma in Tropical Medicine and Hygiene from LSTMH. Stacey has worked with various organizations, including the World Health Organization, NGOs, and the UK government. And we're really thrilled that she's been with us in Resolve to Save Lives, working on this really challenging area and putting in the energy to get us some significant answers to questions that we've had about containing low clinical suspicion. So Stacey, over to you, and we look forward to your presentation.
Great, thank you, Mohammed, and a warm welcome to all of you joining from around the world. It's a real privilege to be able to speak to you today about our work on epidemic-ready primary health care, and in particular, how it can help address 717's top bottleneck to outbreak detection. So next slide, please. So the health facility level remains a major bottleneck in early outbreak detection, driven by low clinical suspicion among frontline healthcare workers. And an analysis done by the Alliance team of 500 bottlenecks from 148 outbreaks across 18 countries showed that low clinical suspicion was the most common bottleneck for outbreak detection, driving delays in nearly 1/3 of outbreaks analysed. Next slide. And so there are many interconnected factors that drive low clinical suspicion. First is related to knowledge and training gaps. Many healthcare workers lack disease-specific knowledge on transmission and clinical signs. From published studies early on in COVID, early COVID recognition was hindered by limited understanding. There was an interesting study published this year of a survey that was done in the DRC a few years back during the Ebola outbreak that showed that only 16% of healthcare workers surveyed had received Ebola-specific training. And so fundamentally, you can't recognize what you don't know. So consistent practical training remains one of the strongest levers to improve clinical suspicion. Second, low confidence in diagnosing emerging diseases. Confidence comes from repetition and experience. And that's exactly what novel or unfamiliar diseases don't allow for. Interestingly, a study published last year from Ethiopia found that only 1/3 of healthcare workers surveyed felt confident in diagnosing mpox, and that confidence was strongly linked to prior training. The third factor relates to poor access to reliable and up-to-date information. When healthcare workers rely on informal or outdated sources, knowledge weakens, and so does clinical suspicion. Those that have access to regular official health information tend to show better knowledge, attitudes, and practices. On top of this, things like atypical or mild presentations can make identification challenging and can often lead to missed early cases. Layered onto this, there are system and infrastructure barriers. So that could be a lack of or weak screening and triage, inadequate infection prevention control infrastructure, unreliable notification systems, or poor access to diagnostics. All of these can impede the ability of healthcare workers to recognize and quickly act. And obviously underpinning everything is the interplay between knowledge, attitudes, and practices. And poor knowledge drives poor attitudes and practices, which together reduce clinical suspicion. Interestingly, attitudes, and in particular, a lack of perceived personal safety of healthcare workers, can reduce vigilance and also suspicion. So the bottom line here is that clinical suspicion is driven, or low clinical suspicion is driven by gaps in knowledge, in confidence, in information access, and in system support. So strengthening training, building healthcare worker confidence, improving infection control and triage systems, and ensuring reliable access to information are really essential for improving suspicion and early detection. Next slide, please. But the impact of low clinical suspicion goes far beyond delayed outbreak detection, as clinical suspicion is really the critical first step that triggers enhanced infection prevention and control measures. So if healthcare workers don't suspect a threat, they can't protect themselves or their patients. And when suspicion is missing, we see a far too common pattern. Outbreaks are detected only after a health worker becomes infected or dies, a tragic and entirely preventable failure of frontline surveillance. Next slide, please. So we can't talk about early outbreak detection without talking about primary healthcare. The vast majority of countries around the world, primary healthcare is the front door of the health system. It's where most people first seek care and where the earliest signs of an outbreak should be recognized. So improving clinical suspicion must start at primary healthcare. But primary healthcare's role in outbreaks and epidemics goes far beyond recognition. Primary healthcare is also essential for maintaining essential health service delivery, delivering medical countermeasures, and protecting communities. But despite this, primary healthcare continues to be under-prioritized, underfunded, understaffed, and often excluded from preparedness planning. And we really saw the impact of this gap very clearly during the COVID pandemic. Many countries struggled to leverage primary healthcare to deliver medical countermeasures, and 94% of countries around the world experience disruptions to essential health service delivery, with the primary care level being the most affected service delivery setting. Next slide, please. So it was really the combination of all of these insights, learning from 717 and from the COVID pandemic, that really signaled the need to strengthen primary healthcare readiness for future epidemics. And it was those insights are what led us at Resolve to Save Lives to develop the concept of epidemic-ready primary healthcare. And over the past 2 years, we've been working to bring this to life, defining the concept, building a practical framework, and testing how to operationalize ERPHC on the ground. Next slide, please. So ERPHC, Epidemic-Ready Primary Healthcare, is an approach to strengthen primary healthcare to prevent, detect, and respond to outbreaks while ensuring the continuity of essential health services. The approach in its most basic level focuses on ensuring that the primary care level can do 3 critical things: rapidly detect and report cases, speed; manage outbreaks safely, protecting staff, patients, and communities, safety; and also handle increased patient volume and maintain essential health service delivery, surge. Next slide, please. So these outcomes are achieved through targeted technical interventions or activities that strengthen 4 core capacities: ensuring that primary care can connect with communities, build trust, share information, and strengthen local readiness for epidemics; detect and report health threats early through effective surveillance and early warning systems, as well as access to diagnostics and laboratory networks; protect themselves and others by implementing infection prevention and control precautions, and also medical countermeasures like vaccination; and also treat those both affected by the epidemic or the outbreak, as well as continue to provide essential health services for their populations. So these 4 capacities really form the foundation of the epidemic-ready primary healthcare approach. Next slide, please. And the logic model, the conceptual framework you see on the screen, shows how strengthening these capacities translates into real-world impact. Together, these capacities drive the outputs of speed, safety, and surge, resulting in timely detection and early response to outbreaks, so really supporting the 717 target, the protection of frontline healthcare workers, as well as the continuity of essential health services, ultimately contributing to reduced morbidity, mortality, and the socioeconomic costs of outbreaks. Next slide, please. Now, while each capacity includes a targeted package of interventions, they must be implemented in coordination and not in vertical silos, as focusing on a single capacity may improve one function, but leaves critical gaps in overall readiness. And this is important when we're thinking about improving clinical suspicion. Detecting a pathogen is essential, but it's not enough on its own. We also need patients to come promptly to health facilities. We also need healthcare workers to know how to protect themselves the moment they suspect a case, as well as to know how to manage that case safely. So the ERPHC approach is not reinventing what we do in emergency preparedness. The interventions that contribute to strengthening each of the capacities themselves aren't new. It's really about transforming how we do it. And integration is the innovation. Ensuring that all parts work together, ensuring that we are, providing interventions and activities that strengthen across the 4 capacities to build epidemic-ready primary healthcare systems. Next slide, please. So although today we're focusing on one bottleneck, low clinical suspicion, I just wanted to highlight that ERPHC has the potential to address many other bottlenecks across 717. On the screen, I've underscored in red bottlenecks that could be addressed by ERPHC interventions. At its core, ERPHC can promote early care seeking, which is another key 717 bottleneck, clinical suspicion among healthcare workers, strengthen immediate reporting pathways, and also ensure health facilities are equipped for rapid containment, surge response, as well as early implementation of countermeasures, thus really helping to ensure that primary healthcare is not only the first to detect, but the first to act rapidly, safely, and effectively. Next slide, please. So that's the concept. Now let's turn to the more interesting part of the presentation and what we've learned operationalizing ERPHC and the connection points to improving clinical suspicion. So over the past 2 years, we've had the pleasure of working with partners to pilot ERPHC in Ethiopia, Nigeria, Sierra Leone, and Uganda. The pilot was implemented at 766 health facilities. There was some scale up during the pilot, so now it's at just over 1,000 facilities. These facilities included public facilities, private facilities. We had urban facilities, very rural facilities, as well as small to large primary healthcare settings. The pilot interventions really focused on 6 core areas. So a big focus and emphasis on strengthening health worker capacity. And this was via training and a longitudinal continuous mentorship approach. It also ensured integration across technical areas. So integrating content across surveillance, infection control, case management. Interventions also looked at improving community facility linkages, enhancing screening and triage practices, as well as referral pathways, strengthening continuity planning for essential services for emergencies. There was regular assessment of capacities and use of that data to drive performance improvements, and then also simulation exercises to test systems and health facilities in practice. And of course, this work's only been possible through collaboration with our government and implementing partners that you can see on the screen. So let me just give a thanks to the respective ministries of health and national public health institutes in the countries, as well as AFINet Nigeria, the Infectious Diseases Institute in Uganda, ICAP Sierra Leone, and the Resolve to Save Lives team in Ethiopia. Next slide, please. So to measure progress during the pilot, we tracked both readiness and real-world functional performance. For readiness, we used a 27 indicator checklist, which was completed monthly during the mentorship visits. And this generated a facility-level ERPHC score that we could track over time. For functional performance, we used 2 approaches. The first, whenever there was a lab-confirmed, immediately notifiable disease, we used an adapted 717 tool for primary care, which I'll come on and talk about in a moment. The second approach was the use of simulation exercises, and we utilized mystery patients to assess in real time how facilities detected, reported, and managed suspected cases in a controlled environment. Next slide, please. So just to go a bit deeper into the adapted 717 tool. So during the pilot, we really wanted to understand what these specific contributions could be of primary healthcare towards achieving 717. So we developed a tool that tracked speed of detection and notification, so capturing the facility's contribution to the first 7 and the 1 of 717. The last 7 is what required adaptation for the primary care level, because the immediate most critical actions that facilities need to take when they have a suspected or a confirmed case, such as isolating patients, wearing the correct PPE, timeliness wasn't quite the right metric, as those actions needed to happen the moment there was a suspected case. So we adapted the last 7 to look at 2 things. The first was safety. So this really looked at the immediate response of the facility to protect patients and staff, looking at, did they isolate the patient? Did the staff wear the right PPE? Did the patient receive the right treatment? We then went on to look at surge. So if the facility saw 1 case of Mpox, how ready would this facility be to see 10 or 20 cases of Mpox? So here we looked at 10 critical surge-related actions. So this tool was completed retrospectively. Each time there was a confirmed case of a priority pathogen. Importantly, this wasn't limited to index cases. We wanted to leverage the learning aspect of 717 and help facilities learn from each real event in order to continuously strengthen their readiness. Next slide, please. So let's get into some of the results. So across the pilot, we saw substantial improvements in health facility readiness. The average health facility readiness score improved from 55% at baseline to 90%, and we saw improvements across all 4 countries. In Nigeria, we were able to pilot alongside control facilities, and we saw a statistically significant difference in performance, with the ERPHC facilities outperforming the control sites in terms of their overall readiness score and how high that score got, as well as their improvement over time. Next slide, please. We saw improved clinical suspicion and response to priority pathogens. So during the pilot, there were 208 confirmed cases detected. This included cholera, diphtheria, measles, mpox, and yellow fever. So giving us a real opportunity to understand performance from real-world events. You can see on the screen the first 7 was met in 90% of the cases, and the notification target was met in 100%. Interestingly, moving down to the graphs on the screen, the most common bottleneck for detection and notification was late presentation to the health facility, accounting for almost half of all bottlenecks. And I think this is really key. So as clinical suspicion improves, the community engagement and the trust to encourage early care seeking becomes even more critical. The enablers are also interesting to take a closer look at what positively drove clinical suspicion. So healthcare worker knowledge being among the top 2. Knowledge in terms of notification pathways and procedures, as well as case definitions and SOPs. And this was followed by the availability of reporting tools and the reliability of notification systems. Next slide, please. In terms of safety actions, these were achieved in 96% of the cases. Interestingly, 100% of the bottlenecks identified here related to a lack of PPE supplies. The main enablers were the availability of SOPs, job aids, and IEC materials for healthcare workers, followed by the availability of PPE and medicine. So really showing the centrality of PPE when it comes to the capacity and ability of healthcare workers to take these immediate safety actions. Next slide, please. In terms of the surge readiness, so you can see on the screen the 10 items that we looked at, and the scores were pretty good apart from one at the bottom, supplies. And supplies, again, were the biggest bottleneck for surge readiness. Only 39% of facilities had adequate supplies if they were to see a surge in cases. And this alone pulled the overall surge readiness down, with only 28% of facilities actually meeting all 10 surge requirements. So again, really highlighting the centrality of the supply piece. Next slide, please. So in Sierra Leone's recent mpox outbreak, we had the opportunity to use this tool and compare ERPHC facilities with control sites. So we compared 12 ERPHC facilities to 10 control sites that between them had seen 172 mpox cases. And we found statistically significant differences. ERPHC facilities detected cases faster, managed them more safely, and were more prepared for surge compared to controls. Next slide, please. So as mentioned, another way we tried to really look at real-world performance was the use of simulation exercises. And for these, we used mystery patients. So community health workers or CSO members were trained to act out scripts. And I have to say, the training was genuinely impressive. You know, some of the CHWs were doing jumping jacks so that they would arrive at the facility tachycardic and sweating. Others were holding water in their mouth so that they would vomit on arrival to the health facility. We had an evaluator that accompanied the mystery patient, and they posed as a caregiver, but were able to assess the facility's response in real time. So in total, we completed 58 of these simulation exercises with an average health facility CIMEX score of 60%. And as you can see from the subdomains, non-clinical systems, but pretty poor when it came to IPC performance. In Ethiopia, we were able to complete these simulations at both ERPHC facilities and control sites, and we saw a significant difference in performance. So the ERPHC facilities scored 64% on average, compared to 35% at control sites, with an odds ratio of 3.2. Meaning the ERPHC facilities were 3 times more likely to perform the correct actions. Next slide, please. But the key learning from these simulations was really the clear gap between preparedness on paper and performance in practice. At the time of the simulation, you can see from the graph on the screen, the average readiness score, so this was from the monthly mentorship tool, was 84%. But the simulation score was 60%. So in other words, facilities were more ready on paper than they were able to respond in practice. So this revealed really important no-do gaps, things that readiness checklists alone simply can't capture. The more that we went into the data and analyzed the data from across the countries and all of the simulation exercises, we identified 5 essential themes that strongly influenced whether facilities actually responded in practice or not. These were captaincy, so leadership qualities and behaviors, with leading by example being a really key element. Consistency, applying the same approach repeatedly as skills and knowledge build, helping healthcare workers to develop muscle memory and avoid guesswork under pressure. Confidence of healthcare workers in their knowledge and skills, as well as communication and cooperation. So trust, teamwork, and how healthcare workers engage and support one another. So these things go beyond technical capacity and really highlight the non-technical areas that we must also strengthen to ensure facilities can actually apply what they learn and translate into real-world performance. And as you can see from the picture on the screen, we're starting to really think about these non-technical competencies as the lubricant that allows the technical capacities to work effectively. Next slide, please. So during the pilot, we also saw improvements in alert reporting, another signal that clinical suspicion was strengthening across facilities. So the number of monthly alerts from 184 at baseline to 365, reflecting that more suspected cases were being recognized and escalated. Facilities were also reporting them faster. The proportion submitted within 24 hours increasing from 81% to 95%, showing stronger linkage between suspicion, recognition, and action. And importantly, we also saw improvements in data use. So weekly trend analysis increased from 56% to 93% at facilities, and IDSR reporting becoming more complete and more timely. So again, reinforcing a culture of vigilance that supports clinical suspicion. Next slide, please. In Uganda, the team were able to look more closely at this and how ERPHC influenced alert generation. So ERPHC was implemented in 19 districts compared with 116 districts without the intervention. So the graph you see shows across EPI weeks the number of alerts being generated. The red bar shows ERPHC districts, and the blue line shows the non-ERPHC districts. So as we look at the left-hand side of the graph before implementation, we see that the non-ERPHC districts are producing more alerts, which isn't surprising, right? We're comparing 19 to 116. What is striking is what happens as we move along the graph into the intervention period, when mentorships and targeted efforts to really build frontline clinical suspicion begin. The 19 ERPHC districts start to outperform the non-ERPHC districts in producing more alerts. And the quality of the alerts was higher too. So a higher proportion of those alerts were escalated, and a fewer proportion of those alerts were deemed unactionable. So again, underscoring the contribution of ERPHC in strengthening clinical suspicion. Next slide, please. So as mentioned, strengthening clinical suspicion is really only the first step. The next step is ensuring that healthcare workers can act safely the moment a case is suspected. So during the pilot, infection prevention and control performance rose from 56% at baseline to 95%, showing major improvements in the safety dimension of the ERPHC model. Facilities dramatically expanded their ability to screen, triage, and isolate suspected cases, jumping from 20% to over 80% for screening, and from 17% to 73% for isolation. We also saw improvements in the basics, but really important, hand hygiene, rising from 43% to 98%. But the numbers only really tell part of the story. And I think the words of Sister Hilda from Wanda Health Center in Uganda that you can see on the screen really capture what these changes meant on the ground for healthcare workers. And she told us, we were scared to open during COVID. We didn't think we could manage. When Ebola came, the staff were really scared, but the mentors guided us, helped us set up triage, screening, and isolation, and gave us confidence. Then anthrax came, and this time we felt ready. We no longer needed to run. And that transformation from fear and uncertainty to confidence and readiness is really what epidemic-ready primary healthcare is all about. And as we discussed earlier, when looking at the drivers of low clinical suspicion, confidence is a core ingredient in building strong clinical suspicion. Next slide, please. So up to this point, I've shared what we were able to achieve through the intensive support at the 700 plus facilities. But during the pilot, we also explored how to strengthen clinical suspicion at scale. How do we reach thousands of healthcare workers quickly and consistently? So to do this, we developed the Clinical Integrated Disease Surveillance and Response, a long phrase, CIDSR course, which is a mobile phone self-paced online training course detecting and managing outbreak-prone diseases. The course is organized into modules. Each focuses on a different pathogen. The material is presented as interactive patient journeys, so how patients actually present to facilities, and equips healthcare workers with foundational knowledge across connect, detect, protect, and treat. So all core to clinical suspicion and early action. We piloted the course in Nigeria and Uganda and tested 2 use cases. So the first was piloting this as a complete course where healthcare workers took all of the modules. They received a certificate and CPD credits. And to date, more than 33,000 healthcare workers have completed the full course with statistically significant learning gains. The second use case, which personally I think was super interesting, was deploying standalone modules as just-in-time training. So when risk changes, so that could be we're coming into rainy season and the risk of cholera is increasing, or at the outset of a confirmed outbreak, we were able to push out the relevant modules. And you can see from the examples, the second table on the screen, the different outbreaks that we utilized this for. And one example I wanted to highlight is from Nigeria and cholera. So nearly 3,000 healthcare workers completed the cholera module within 72 hours, and almost 6,000 healthcare workers completed within 1 week from across the country. So showing both strong demand and the feasibility of rapid nationwide reach, and certainly the pace impossible to achieve with in-person training. Knowledge gains were also significant, and more than 97% of respondents have reported improved confidence to identify and report cases. So both of these essential components of strong clinical suspicion. So CIDSR has proven to be a valuable and scalable way to reach thousands of healthcare workers quickly, strengthening both knowledge and confidence required for early detection. Next slide, please. So we also asked almost 1,500 healthcare workers for their feedback on the pilot, and the results were really clear. 99% of them agreed that ERPHC had strengthened epidemic readiness at their facility, showing that these changes were also felt and experienced at the front line. Most importantly for today's discussion, 99% reported improved clinical suspicion. 98% felt more confident in infection prevention and control, and 93% feeling more confident in managing cases. So together, these findings tell us that strengthening clinical suspicion is not just possible, but achievable, and fundamentally changes how frontline healthcare workers feel and perform. Next slide, please. So our results show that investments in epidemic-ready primary healthcare can rapidly strengthen facility readiness and performance. We saw measurable improvements in speed, safety, and surge capacity, all anchored in stronger clinical suspicion at the front line. And from this, three key lessons that areas, connect, detect, protect, and treat, ensures that healthcare workers have the full set of cues and systems needed to not only recognize but act on suspected cases, aligning and enforce consistent practice. The second, mentorship accelerates progress. So unlike one-off trainings, ongoing mentorship helps healthcare workers build the confidence and practical skills required for clinical suspicion. Mentorship really bridges that no-do gap, strengthening real-time decision-making, reinforcing case definitions, and supporting correct IPC actions the moment suspicion is raised. And third, supply and infrastructure gaps. So even when knowledge and confidence are strong, clinical suspicion cannot translate into action without adequate PPE, without infrastructure for screening, for triage, for isolation. So closing these gaps is essential to sustain high clinical suspicion and ensure healthcare workers can act immediately and safely when they identify unusual symptoms. Next slide, please. So I want to close by bringing this back to what matters most, people, and especially healthcare workers. And as we discussed at the start, low clinical suspicion isn't just a delay, it's a danger. And in too many outbreaks, that danger becomes real when a healthcare worker is infected or dies. The two very different stories on the screen are from the same country, in the same city, in fact. This is Kampala, Uganda, just 1 month apart. At the top is a headline from the Ebola outbreak earlier this year, suspected following the death of a nurse. And on the bottom is a reflection from a private facility in Kampala involved in the ERPHC pilot. And when I visited this facility, they were extremely engaged with the project. And I was very intrigued as a private facility, what motivated them to engage with this project. And this is what the facility owner told me. Previously, 2 to 3 healthcare workers would be infected during outbreaks. And she went on to say, this cost me money in terms of paying for extra staff and paying for their medical bills. And now there are no infections. Staff know what to do. Screening is done properly. Suspected cases are identified and isolated. And this is exactly what happened with recent Mpox cases. None of our staff were exposed. So this is what ERPHC can make possible, changing the story, protecting those on the front lines so that they can continue to do what they do best, care for and protect the communities they serve. And with that, let me stop there and happy to take any questions.
Stacey, thank you for a really fantastic presentation. We often don't talk about silver bullets in public health, right? But your presentation today looks like the closest imitation to a silver bullet. You've told us about, an integrated approach that strengthens IPC, enhances surveillance, ensures continuity of care, and even has that linkage with the communities. And the results are really quite striking. You are aware we've worked on 717. We've largely talked about reducing that time to detection as one of those really wicked problems, really significant challenges. But here you present a single approach where this has empowered health workers to detect within that first 7 up to 90% of the time. And so the question that I think our community is having, and they've sent a lot of requests for your slides, for information, checklists, is really, how far is this gone in terms of, introduction into global normative guidance? How far has this gone in terms of demand, for example, beyond the countries where the pilot has happened? Can you just give us an update in terms of where things stand in terms of implementation more widely?
Yeah, sure. So in terms of the framework, so the first thing to say with the framework, this obviously all started focused on epidemics, epidemic-ready primary healthcare. We have made a pivot with the framework to pivot from epidemic-ready primary healthcare to emergency-ready primary healthcare. And that's recognizing that, whilst the origins of emergencies vary, their impact on health systems tend to be, pretty universal. So the type of preparedness measures or readiness measures that we need to do at primary care for epidemics won't be drastically different to what we need to be thinking about in terms of climate related or non-epidemic hazards. So the concept of speed, safety, surge really kind of holds. So the first thing to say is with the framework, we've made that pivot to emergency ready primary healthcare. The framework's already available. The framework, is very detailed. It's very broad. It outlines, all of the different technical interventions that would support each of the capacities. I think from last count, there's about 50 different technical interventions as part of the framework. So the first thing to say with the framework is it's not intended to be take the framework and implement the entirety of the framework. The framework's really intended to be a starting place for countries to really contextualize and prioritize the interventions most needed to drive those capacities in their own context. So with regards to the framework, I'm really happy to say that we're currently collaborating with WHO to validate the framework. That work is well underway, and we're hoping to have that formally published as global guidelines early next year. And that will be published, the framework will be published alongside an operational guide for countries that will provide some additional guidance and tools to countries on how to use the framework. At Resolve, we are busy constantly developing tools and resources and testing them out and improving them. So we have a co-creation package available. I was in Nigeria a few weeks back supporting the government with a co-creation workshop to take the framework and to really adapt, contextualize, and prioritize. There's also a self-assessment tool that could help countries, again, take the framework, really understand where they are across the different capacities and intervention. So all to say, there's a lot of tools and resources. A QR code on the screen will take you to our website where you will find some. Very happy to be contacted for more. And early next year, this will all be coming out with WHO, and we're hoping to formally launch at the World Health Assembly next year, which is like super exciting. Very excited about it.
Congratulations, Stacey. It's really, really exciting progress that you've made. Outbreaks don't really wait for us to get organized. As you very well know, currently supporting our response in Ethiopia. Tell us a bit more about the just-in-time training. That's something that can be deployed right away. The demand for it is often driven by the motivation of the healthcare worker to learn more about the disease. But if you're going to make something that is locally adapted to that country's surveillance and reporting system, that can be challenging doing that right in the midst of an outbreak. But what is your experience in terms of expanding that just-in-time training to new countries, territories during outbreaks?
Yeah, I mean, I have to say, CIDSR has been a super interesting part of this pilot, and the just-in-time piece is something that's been really close to my heart. So, having been on the ground at the outset of, lots of different outbreaks and multiple different VHF outbreaks, there's always a real need for healthcare workers at the outset to receive information as quickly as possible. And it often takes time for the response to kind of kick in, for the pillars to get organized, for us to, do in-person training. And so I think this solution of being able to get up-to-date factual information blasted very quickly to frontline healthcare workers, I think, fills a really, really critical and important gap. I think so far with CIDSR, our approach today is we've made it very country specific. So specifically to those countries, the content is built around the country specific guidelines, and it includes, really specific details like, if you need to report a suspected case of Ebola, this is the phone number to call. So, and what we've seen when we started in Nigeria, when we then adapted to Uganda, the adaptation of the modules and the content can be done quite quickly, actually. So I think there's certainly benefit for the country specific courses, but obviously that
Right.
means, that becomes less efficient when we think about a broader scale. And I was thinking about this, a few months back when, as a continent, the African continent had Mpox outbreaks in multiple different countries. And we have this Mpox module that was serving a good purpose in two countries. So starting to think about, okay, is there a better pathway to scale in terms of the reach of this course? And I think that the pathway is actually probably a regional platform. So when you look at the content, the content takes healthcare workers, through that detection, the surveillance piece, into the, protection piece, into the treatment, the messages for communities. I would say 90% of the content's generic. The infection prevention control measures for Ebola are the infection prevention control measures for Ebola. I think the 10% that is not generic really comes down to the exact phone number that someone needs to call if they've got a suspected case. So I think there's a trade-off there. I think if we went more with a regional platform and offering, obviously, being able to make this, more widely available as a form of just-in-time training would be fantastic. But we would lose some of that specificity, particularly around the surveillance training. But again, very happy to have conversations with countries if they're interested in a country-specific CIDSR course. Thanks.
Thank you. Now, just a quick follow-up on the CIDSR courses. A a question has come up as how do you select those priority pathogens or outbreaks in each country?
Well, the countries do. We don't, the countries do. And it was quite interesting, actually. I think so Uganda and Nigeria chose different pathogens and for different reasons. So Nigeria prioritized pathogens based on the threats they most commonly see. They went with a kind of let's prioritize the modules for the outbreaks that we commonly see in country and utilize that as a resource for those. Uganda's thinking was quite different. Uganda went with, okay, common things are common, and healthcare workers have probably had lots of training on cholera. So let's prioritize pathogens that are less common, and we know healthcare workers will have had less training on. So in Uganda, we went with, much rarer pathogens as well. So, ultimately it's really up to countries what, pathogens are, most relevant for the course. And as I said, there are, different ways to think about selecting pathogens. I should also note
Thanks.
as well, we've recently just piloted in Zambia. We've just launched one pilot cholera module in Zambia as well.
Now, there was a slide that you presented that showed a fall off in terms of alerts, was the alert generation slide. What do you think was responsible for the decline in alerts generated from the non-ERPHC sites?
Yeah, I mean, great question. And the honest answer is I've no idea. And I think it's, you could either look at it two ways. Is it a decline in one or an incline in another? And actually, I think, this was more an increase and a drive from the ERPHC facilities, which proportionately changed things, as opposed to a genuine, decline from the other districts. I think what we've seen across the pilot is, and what's been very interesting is how basic and common some of the bottlenecks are. So when we've, looked closer at alert generation, and in particular when we've looked at reasons why alerts either don't get reported or they don't get reported quickly, the reasons behind that are really basics. Usually things like, well, they only trained one person in this big facility, and this one person wasn't here today, so no one reported the alert. Or sometimes the reliability of the tech that's being used to report. So I think with ERPHC, what's been really interesting is we've taken an approach to kind of move away from having just focal points, one focal point at a facility, and started to think about, okay, what is the minimum, basic kind of competencies or capacities, if you like, that every healthcare worker needs to have. And so we've done a real drive at facilities to ensure that they all know how to report alerts. And I think, tackling, some of those basic bottlenecks and increasing the number of people that know how to raise an alert basically meant that we saw more alerts actually being raised. So I think it was more that we were driving up alerts and there was a genuine drop in alerts from non-supported districts.
Excellent. I would say two philosophical questions, which perhaps you don't need to answer. The first one is from a One Health specialist in our audience, and he's asked a question that, should we be focused more on low clinical suspicion in humans or low clinical suspicion in animals when we're dealing with One Health outbreaks? I mean, where would we see the greater impact? So you don't need to answer that one first. And then the second one is really, how long do these benefits last? We've seen the capacity building, we've seen the improvements in things like hand hygiene. What is the longevity of the effect of this intervention? And do you have any follow-on work to measure that?
We are, still in the pilot period. So this pilot, a 2-year pilot, will be formally ending next month. So I think that broader question of how long does this last is yet to be answered, and it's an excellent, piece for us to look at. One thing we have done, during the pilot to really support the sustainability is we've task shifted with time the mentorship piece from what was external mentors coming from either, the subnational level or from government health workers from other facilities. We've task shifted that inside the facility to focal points. Typically, when we see task shifting, and when I've seen that before in projects, you usually see, performance and capacity drop pretty much straight away or quite soon after that. So far across the 4 countries, 3-4 months into task shifting, and we've seen performance sustain and stay very high, which for me is an excellent indication and sign. We also, when we did the survey, I showed you the survey results at the end, and we asked healthcare workers, 78% of the healthcare workers felt that the changes that were made at the facility could be sustained without external support, which I thought actually was extremely encouraging. So all I can say right now is, I think the signs and indications of this lasting look positive, but only time's going to tell. Once the pilots that, is finished in terms of how long these changes can be sustained. Going back to the first question on One Health and, where is the juice worth the squeeze? Low clinical suspicion in humans or animals. I think that's a really contextual question. And I think you have to really look at, what is driving outbreaks in a particular country and what is driving high impact outbreaks in a country. And that could be coming from the animal side, from the human side, or from both. And I think, it is possible to put emphasis on both. And certainly, with the ERPHC approach, infections that start, zoonotic on the animal side, once they get into humans, they often find their way into facilities. So this is where this project will be picking those pieces up.
Thank you very much, Stacey. It's really been wonderful listening to you and really understanding some of the implementation steps you've taken with your pilot. Congratulations on the results. And we do look forward to hearing more about this work, particularly after the launch of the global guidance. So thank you very much, Stacey.
You're welcome.
So colleagues, we're coming to the end of our session. And really, one of the last things we wanted to talk about is one of the programs that we have called Epidemics That Didn't Happen. Epidemics That Didn't Happen is an initiative that we have to really get some good cases of outbreaks that have been stopped in their tracks due to early action. So please, if you do have a case that could fit this initiative, please do reach out to us. We should be able to work with you to develop the case. It's written more in journalism format rather than scientific format. But we do think that this messaging about how early action really prevents morbidity, mortality, and reduces the duration of outbreaks is a critical message that needs to go out more and more today. So I want to thank everybody that has made time to join us for this 717 Alliance webinar. We look forward to connecting with you in 2026 with another interesting topic. So thank you very much and have a wonderful day.